Regulation concept exemplar, cirrhosis. Cirrhosis is extensive, irreversible scarring of the liver, usually caused by a chronic reaction to hepatic inflammation and necrosis. This scarring process directly impairs cellular regulation. The disease typically develops slowly and has a progressive, prolonged, destructive course resulting in end-stage liver disease. Pathophysiology review. Cirrhosis is characterized by widespread fibrotic bands of connective tissue that change the liver's anatomy and physiology. Inflammation caused by either toxins or disease results in extensive degeneration and destruction of hepatocytes. As cirrhosis develops, the tissue becomes nodular. These nodules can block bile ducts and normal blood flow throughout the liver. Impairments in blood and lymph flow result from compression caused by excessive fibrous tissue. In early disease, the liver is usually enlarged and firm. As the pathologic process continues, the liver shrinks in size and becomes harder, resulting in decreased liver function over weeks to years. Some patients with cirrhosis have no symptoms until serious complications occur. The impaired liver function results in elevated serum liver enzymes. Cirrhosis of the liver can be divided into several common types, depending on the cause of the disease. 1. Post-necrotic cirrhosis. 2. Lanex or alcoholic cirrhosis. 3. Biliary cirrhosis. Complications of cirrhosis. Common problems and complications associated with hepatic cirrhosis depend on the amount of damage sustained by the liver. In compensated cirrhosis, the liver is scarred and cellular regulation is impaired, but the organ can still perform essential functions without causing major symptoms. In decompensated cirrhosis, liver function is impaired with obvious signs and symptoms of liver failure. The loss of hepatic function contributes to the development of metabolic abnormalities. Hepatic cell damage may lead to these common complications. 1. Portal hypertension. 2. Ascites and esophageal varices. 3. Biliary obstruction. 4. Hepatic encephalopathy. Portal hypertension. Portal hypertension, a persistent increase in pressure within the portal vein greater than 5 mm of mercury, is a major complication of cirrhosis. It results from increased resistance to or obstruction of the flow of blood through the portal vein and its branches. The blood meets resistance to flow and seeks collateral venous channels around the high-pressure area. Blood flow backs into the spleen, causing splenomegaly. Veins in the esophagus, stomach, intestines, abdomen, and rectum become dilated. Portal hypertension can result in ascites, esophageal varices, prominent abdominal veins, and hemorrhoids. Ascites and gastroesophageal varices. Ascites is the collection of free fluid within the peritoneal cavity caused by increased hydrostatic pressure from portal hypertension. The collection of plasma protein in the peritoneal fluid reduces the amount of circulating plasma protein in the blood. When this decrease is combined with the inability of the liver to produce albumin because of impaired liver cell functioning, the serum colloid osmotic pressure is decreased in the circulatory system. The result is a fluid shift from the vascular system into the abdomen, a form of third spacing. As a result, the patient may have hypovolemia and edema at the same time. Massive ascites may cause renal vasoconstriction, triggering the renin-angiotensin system. This results in sodium and water retention, which increases hydrostatic pressure and the vascular volume and leads to more ascites. As a result of portal hypertension, the blood backs up from the liver and enters the esophageal and gastric veins. Esophageal varices occur when fragile, thin-walled esophageal veins become distended and tortuous from increased pressure. The potential for varices to bleed depends on their size. Size is determined by direct endoscopic observation. Varices occur most often in the distal esophagus but can be present also in the stomach and rectum. Decreased prothrombin production places the patient with cirrhosis at risk for bleeding. Bleeding esophageal varices are a life-threatening medical emergency. Severe blood loss may occur, resulting in shock from hypovolemia. The bleeding may present as either hematemesis or melena. Loss of consciousness may occur before any observed bleeding. Variceal bleeding can occur spontaneously with no precipitating factors. However, any activity that increases abdominal pressure may increase the likelihood of a variceal bleed, including heavy lifting or vigorous physical exercise. In addition, chest trauma or dry, hard food in the esophagus can cause bleeding. Figure 531 jaundice as a result of liver dysfunctions such as cirrhosis and hepatitis. From Leonard P.C. Quick and easy medical terminology. St. Louis, Elsevier. Patients with portal hypertension may also have portal hypertensive gastropathy. This complication can occur with or without esophageal varices. Slow gastric mucosal bleeding occurs, which may result in chronic slow blood loss, occult-positive stools, and anemia. Splenomegaly results from the backup of blood into the spleen. The enlarged spleen destroys platelets, causing thrombocytopenia and increased risk for bleeding. Thrombocytopenia is often the first clinical sign that a patient has liver dysfunction. Biliary obstruction. In patients with cirrhosis, the production of bile in the liver is decreased. This prevents the absorption of fat-soluble vitamins. Without vitamin K, clotting factors 2, 7, 9, and X are not produced in sufficient quantities, and the patient is susceptible to bleeding and easy bruising. These abnormalities are confirmed by coagulation studies. Some patients have a genetic predisposition to obstruction of the bile duct that leads to biliary cirrhosis, usually from gallbladder disease or an autoimmune form of the disease called primary biliary cirrhosis. Jaundice in patients with cirrhosis is caused by one of two mechanisms: hepatocellular disease or intrahepatic obstruction. Hepatocellular jaundice develops because the liver cells cannot effectively excrete bilirubin. This decreased excretion results in excessive circulating bilirubin levels. Intrahepatic obstructive jaundice results from edema, fibrosis, or scarring of the hepatic bile channels and bile ducts, which interferes with normal bile and bilirubin excretion. Patients with jaundice often report pruritus. Hepatic encephalopathy. Hepatic encephalopathy is a complex cognitive syndrome that results from liver failure and cirrhosis. Patients report sleep disturbance, mood disturbance, mental status changes, and speech problems early as this complication begins. Hepatic encephalopathy may be reversible with early intervention. Later neurologic symptoms include an altered level of consciousness, impaired thinking processes, and neuromuscular problems. Table 531. Stage I. Subtle manifestations that may not be recognized immediately. Personality changes. Behavior changes. Emotional lability. Impaired thinking. Inability to concentrate. Fatigue. Drowsiness. Slurred or slowed speech. Sleep pattern disturbances. Stage 2. Continuing mental changes. Mental confusion. Disorientation to time, place, or person. Asterixis. Stage 3. Progressive deterioration. Marked mental confusion. Stuporous, drowsy but arousable. Abnormal electroencephalogram tracing. Muscle twitching. Hyperreflexia. Asterixis. Stage 4. Unresponsiveness, leading to death in most patients progressing to this stage. Unarousable, obtunded. Usually no response to painful stimulus. No asterixis. Positive Babinski sign. Muscle rigidity. Fader hepaticus. Seizures. Stages of hepatic encephalopathy. Hepatic encephalopathy may develop slowly in patients with chronic liver disease and go undetected until the late stages. Symptoms develop rapidly in acute liver dysfunction. 4 stages of development have been identified. The patient's symptoms may gradually progress to coma or fluctuate among the 4 stages. The exact mechanisms causing hepatic encephalopathy are not clearly understood but probably are the result of the shunting of portal venous blood into the central circulation, so the liver is bypassed. As a result, substances absorbed by the intestine are not broken down or detoxified and may lead to metabolic abnormalities, such as elevated serum ammonia and gamma-aminobutyric acid. Elevated serum ammonia results from the inability of the liver to detoxify protein byproducts and is common in patients with hepatic encephalopathy. However, it is not a clear indicator of the presence of encephalopathy. Some patients may have major impairment without high elevations of serum ammonia, and elevations of ammonia can occur without evidence of encephalopathy. Factors that may contribute to or worsen hepatic encephalopathy in patients with cirrhosis include 1. High protein diet. 2. Infection. 3. Hypovolemia. 4. Hypokalemia. 5. Constipation. 6. GI bleeding. 7. Drugs. The prognosis depends on the severity of the underlying cause, precipitating factors, and degree of liver dysfunction. Other complications. The development of hepatorenal syndrome indicates a poor prognosis for the patient with liver failure. It is often the cause of death in these patients. This syndrome is manifested by 1. A sudden decrease in urinary flow. 2. Elevated blood urea nitrogen and creatinine levels with abnormally decreased urine sodium excretion. 3. Increased urine osmolarity. Hepatorenal syndrome often occurs after clinical deterioration from GI bleeding or the onset of hepatic encephalopathy. It may also complicate other liver diseases, including acute hepatitis and fulminant liver failure. Patients with cirrhosis and ascites may develop acute spontaneous bacterial peritonitis. Those who are particularly susceptible are patients with very advanced liver disease. This may be the result of low concentrations of proteins. Proteins normally provide some protection against bacteria. The bacteria responsible for SBP are typically from the bowel and reach the acidic fluid after migrating through the bowel wall and traversing the lymphatics. Symptoms vary but may include fever, chills, pain, and tenderness. However, indications can also be minimal with only mild symptoms in the absence of fever. Worsening encephalopathy and increased jaundice may also be present without abdominal symptoms. The diagnosis of SBP is made when a sample of acidic fluid is obtained by paracentesis for cell counts and culture. An acidic fluid leukocyte count of more than 250 polymorphonuclear leukocytes may indicate the need for treatment. Another major complication of cirrhosis is hepatopulmonary syndrome caused by excessive acidic volume. The client experiences dyspnea as a result of intra-abdominal pressure, which limits thoracic expansion and diaphragmatic excursion. Etiology and genetic risk. The most common causes for cirrhosis in the United States are chronic alcoholism, chronic viral hepatitis, and bile duct disease. Hepatitis C is a leading cause of cirrhosis and liver cancer in the United States. It is an infectious blood-borne illness that usually causes chronic disease and compromises the body's immunity. Inflammation caused by infection over time leads to progressive scarring of the liver. It usually takes decades for cirrhosis to develop, although alcohol use in combination with hepatitis C may speed the process. Table 532. Alcoholic liver disease drugs and chemical toxins. Viral hepatitis gallbladder disease. Autoimmune hepatitis metabolic/genetic causes. Steatohepatitis cardiovascular disease. Common causes of cirrhosis. Hepatitis B and hepatitis D are the most common causes of cirrhosis worldwide. Hepatitis B also causes inflammation and low-grade damage over decades that can ultimately lead to cirrhosis. Hepatitis D virus can infect the liver but only in people who already have hepatitis B. Cirrhosis may also occur as a result of non-alcoholic fatty liver disease, a rapidly growing healthcare concern. NAFLD is associated with aging, obesity, diabetes mellitus type 2, and metabolic syndrome. This disease can progress to liver cancer, cirrhosis, or failure, causing premature death. Up to 30% of Americans may have NAFLD. The Paddington-like phospholipase domain-containing 3 gene has been identified as a risk gene for the disease. Latinos have this gene more often than other ethnic groups and therefore are at the highest risk for NAFLD. Another common cause of cirrhosis is excessive and prolonged alcohol use. Alcohol has a direct toxic effect on the hepatocytes and causes liver inflammation. The liver becomes enlarged, with cellular degeneration and infiltration by fat, leukocytes, and lymphocytes. Over time, the inflammatory process decreases and the destructive phase increases. Early scar formation is caused by fibroblast infiltration and collagen formation. Damage to the liver tissue progresses as malnutrition and repeated exposure to the alcohol continue. If alcohol is withheld, the fatty infiltration and inflammation are reversible. If alcohol use continues, widespread scar tissue formation and fibrosis infiltrate the liver as a result of cellular necrosis. The long-term use of illicit drugs, such as cocaine, has similar effects on the liver. Patient-centered care, gender health considerations. The amount of alcohol necessary to cause cirrhosis varies widely from individual to individual, and there are gender differences. In women, it may take as few as 2 or 3 drinks per day over a minimum of 10 years. In men, perhaps 6 drinks per day over the same time period may be needed to cause disease. However, a smaller amount of alcohol over a long period of time can increase memory loss from alcohol toxicity of the cerebral cortex. Binge drinking can increase risk for hepatitis and fatty liver. Incidence and prevalence. Approximately 32 million Americans have hepatitis C, and 1 in 7 Americans have hepatitis B, which can particularly affect Asian American and Pacific Islander-born individuals. Combined, the incidence of chronic liver disease and cirrhosis is a major common cause of death in the United States. The national prevalence of hepatitis B in Canada is 270,000 individuals. It is more challenging to quantify the exact number of Canadians with liver disease, since these statistics are grouped with other digestive disorders. However, it is known that approximately 7,000 Canadians die annually after being affected with a liver disorder. Interprofessional collaborative care. Care for the patient with cirrhosis can take place in various settings by many members of the interprofessional healthcare team. These patients may, at different times, self-manage at home, be hospitalized for immediate concerns, need rehabilitative care, or be cared for in the community setting, including possible hospice care. Assessment, recognize cues. History. Obtain data from patients with suspected cirrhosis, including age, gender, and employment history, especially history of exposure to alcohol, drugs, use of herbal preparations, and chemical toxins. Keep in mind that all exposures are important, regardless of how long ago they occurred. Determine whether there has ever been a needle stick injury. Sexual history and orientation may be important in determining an infectious cause for liver disease, because men having sex with men are at high risk for hepatitis A, hepatitis B, and hepatitis C. People with hepatitis can develop cirrhosis. Inquire about whether there is a family history of alcoholism and/or liver disease. Ask the patient to describe his or her alcohol intake, including the amount consumed during a given period. Is there a history of illicit drug use, including oral, fore, and intranasal forms? Is there a history of obtaining tattoos? If so, when and where were they done? Has the patient been in the military or in prison? Is the patient a healthcare worker, firefighter, or police officer? For patients previously or currently in an alcohol or drug recovery program, how long have they been sober? This information is sensitive and often difficult for the patient to answer. Be sure to establish why you are asking these questions and accept answers in a non-judgmental manner. Provide privacy during the interview. For many people, the behaviors causing the liver disease occurred years before the onset of their current illness, and they are regretful and often embarrassed. Ask the patient about previous medical conditions, such as an episode of jaundice or acute viral hepatitis, biliary tract disorders, viral infection, surgery, blood transfusions, autoimmune disorders, obesity, altered lipid profile, heart failure, respiratory disorders, or liver injury. Physical assessments/signs and symptoms. Because cirrhosis has a slow onset, many of the early signs and symptoms are vague and nonspecific. Assess for 1. Fatigue. 2. Significant change in weight. 3. GI symptoms, such as anorexia and vomiting. 4. Pining the abdominal area and liver tenderness. Liver function problems are often found during a routine physical examination or when laboratory tests are completed for an unrelated illness or problem. The patient with compensated cirrhosis may be completely unaware that there is a liver problem. The first sign may present before the onset of symptoms when routine laboratory tests, pre-surgical evaluations, or life and health insurance assessments show abnormalities. These tests could indicate abnormal liver function or thrombocytopenia, requiring a more thorough diagnostic workup. The development of late signs of advanced cirrhosis usually causes the patient to seek medical treatment. GI bleeding, jaundice, ascites, and spontaneous bruising indicate poor liver function and complications of cirrhosis. Thoroughly assess the patient with liver dysfunction or failure because it affects every body system. The clinical picture and course vary from patient to patient, depending on the severity of the disease. Assess for the common late disease signs and symptoms outlined in the Key Features, Late-Stage Cirrhosis box. Key Features. Late-Stage Cirrhosis. 1. Jaundice and icterus. 2. Dry skin. 3. Pruritus. 4. Rashes. 5. Purpuric lesions, such as petechiae or ecchymoses. 6. Warm and bright red palms of the hands. 7. Vascular lesions with a red center and radiating branches, known as spider angiomas, on the nose, cheeks, upper thorax, and shoulders. 8. Ascites. 9. Peripheral dependent edema of the extremities and sacrum. 10. Vitamin deficiency. Abdominal assessment. Massive ascites can be detected as a distended abdomen with bulging flanks. The umbilicus may protrude, and dilated abdominal veins may radiate from the umbilicus. Ascites can cause physical problems. For example, orthopnea and dyspnea from increased abdominal distension can interfere with lung expansion. The patient may have difficulty maintaining an erect body posture, and problems with balance may affect walking. Inspect and palpate for the presence of inguinal or umbilical hernias, which are likely to develop because of increased intra-abdominal pressure. Minimal ascites is often more difficult to detect, especially in the obese patient. When performing an assessment of the abdomen, keep in mind that hepatomegaly occurs in many cases of early cirrhosis. Splenomegaly is common in non-alcoholic causes of cirrhosis. As the liver deteriorates, it may become hard and small. Measure the patient's abdominal girth to evaluate the progression of ascites. To measure abdominal girth, the patient lies flat while the nurse or other examiner pulls a tape measure around the largest diameter of the abdomen. The girth is measured at the end of exhalation. Mark the abdominal skin and flanks to ensure the same tape measure placement on subsequent readings. However, taking daily weights is the most reliable indicator of fluid retention. Other physical assessment. Observe vomitus and stool for blood. This may be indicated by frank blood in the excrement or by a positive fecal occult blood test. Gastritis, stomach ulceration, or oozing esophageal varices may be responsible for the blood in the stool. Note the presence of Fater hepaticus is the distinctive breath odor of chronic liver disease and hepatic encephalopathy and is characterized by a fruity or musty odor. Amenorrhea may occur in women, and men may exhibit testicular atrophy, gynecomastia, and impotence as a result of inactive hormones. Continually assess the patient's neurologic function. It may also be helpful to include family members in conversations about the patient's baseline mental status if the patient is unable to effectively communicate. Subtle changes in mental status and personality often progress to coma, a late complication of hepatic encephalopathy. Monitor for hysterexis, a coarse tremor characterized by rapid, non-rhythmic extensions and flexions in the wrists and fingers. Psychosocial assessment. The patient with hepatic cirrhosis may undergo subtle or obvious personality, cognitive, and behavior changes, such as agitation. He or she may experience sleep pattern disturbances or exhibit signs of emotional lability, euphoria, or depression. A psychosocial assessment identifies needs and helps guide care. Repeated hospitalizations are common for patients with cirrhosis. It is a life-altering chronic disease, impacting not only the patient but also the immediate and extended family members and significant others. There are significant emotional, physical, and financial changes. Substance use may continue even as health worsens. It is important, whenever possible, to use resources available to these patients and their families. Collaborate with social workers, substance use counselors, and mental health/behavioral healthcare professionals as needed for patient assessment and management. Part of the psychosocial assessment is determining if the patient is alcohol dependent. If this is the case, observe and prepare for alcohol withdrawal. Alcohol withdrawal occurs after stopping alcohol intake after heavy and prolonged use. Monitor for tremors, sometimes called the jitters, which can begin as early as 6 to 8 hours after alcohol cessation. Cognitive and neurologic changes associated with delirium tremens may include acute confusion, anxiety, and psychotic behaviors, such as delusions and hallucinations. Autonomic changes may include tachycardia, elevated blood pressure, and diaphoresis. Care of the patient experiencing withdrawal can be a medical emergency. Consult mental health textbooks for more information about caring for the alcohol-dependent patient. Laboratory assessment. Laboratory study abnormalities are common in patients with liver disease. Serum levels of aspartate aminotransferase, alanine aminotransferase, and lactate dehydrogenase typically are elevated because these enzymes are released into the blood during hepatic inflammation. However, as the liver deteriorates, the hepatocytes may be unable to create an inflammatory response, and the AST and ALT may be normal. ALT levels are more specific to the liver, whereas AST can be found in muscle, kidney, brain, and heart. An AST/ALT ratio greater than 10 is usually found in alcoholic liver disease. Increased alkaline phosphatase and gamma-glutamyl transpeptidase levels are caused by biliary obstruction and therefore may increase in patients with cirrhosis. Alkaline phosphatase is a nonspecific bone, intestinal, and liver enzyme. However, alkaline phosphatase also increases when bone disease, such as osteoporosis, is present. Total serum bilirubin levels also rise. Indirect bilirubin levels increase in patients with cirrhosis because of the inability of the failing liver to excrete bilirubin. Therefore, bilirubin is present in the urine in increased amounts. Fecal urobilinogen concentration is decreased in patients with biliary tract obstruction. These patients have light or clay-colored stools. Total serum albumin levels are decreased in patients with severe or chronic liver disease as a result of decreased synthesis by the liver. Loss of osmotic pole proteins such as albumin promotes the movement of intravascular fluid into the interstitial tissues. Prothrombin time/international normalized ratio is prolonged because the liver decreases the production of prothrombin. The platelet count is low, resulting in a characteristic thrombocytopenia of cirrhosis. Anemia may be reflected by decreased red blood cell, hemoglobin, and hematocrit values. The white blood cell count may also be decreased. Ammonia levels are usually elevated in patients with advanced liver disease. Serum creatinine may be elevated in patients with deteriorating kidney function. Dilutional hyponatremia may occur in patients with ascites. Table 533. Abnormal finding significance. Serum enzymes. Elevated serum aspartate aminotransferase hepatic cell destruction, hepatitis. Elevated serum alanine aminotransferase hepatic cell destruction, hepatitis. Elevated lactate dehydrogenase hepatic cell destruction. Elevated serum alkaline phosphatase obstructive jaundice, hepatic metastasis. Elevated gamma-glutamyl transpeptidase biliary obstruction, cirrhosis. Bilirubin. Elevated serum total bilirubin hepatic cell disease. Elevated serum direct conjugated bilirubin hepatitis, liver metastasis. Elevated serum indirect unconjugated bilirubin cirrhosis. Elevated urine bilirubin hepatocellular obstruction, viral or toxic liver disease. Elevated urine urobilinogen hepatic dysfunction. Decreased fecal urobilinogen obstructive liver disease. Serum proteins. Increased serum total protein acute liver disease. Decreased serum total protein chronic liver disease. Decreased serum albumin severe liver disease. Elevated serum globulin immune response to liver disease. Other tests. Elevated serum ammonia advanced liver disease or portal systemic encephalopathy. Prolonged prothrombin time or international normalized ratio hepatic cell damage and decreased synthesis of prothrombin. Assessment of abnormal laboratory findings in liver disease. NCLEX Examination Challenge 531. Physiological integrity. The nurse is caring for a client who is diagnosed with cirrhosis. Which serum laboratory value will the nurse expect to be abnormal? Select all that apply. A. Prothrombin time. B. Serum bilirubin. C. Albumin. D. Aspartate aminotransferase. E. Lactate dehydrogenase. F. Acid phosphatase. Imaging assessment. Plain X-rays of the abdomen may show hepatomegaly, splenomegaly, or massive ascites. A CT scan may be requested. MRI is another test used to diagnose the patient with liver disease. It can reveal mass lesions, giving additional specific information. This information is helpful in determining whether the condition is malignant or benign. Other diagnostic assessment. Ultrasound of the liver is often the first assessment for an adult with suspected liver disease to detect ascites, hepatomegaly, and splenomegaly. It can also determine the presence of biliary stones or biliary duct obstruction. Liver US with Doppler is useful in detecting portal vein thrombosis and evaluating whether the direction of portal blood flow is normal. Ultrasound transient elastography is a non-invasive test that measures liver stiffness, which helps the primary healthcare provider determine the amount of liver disease present. The normal amount of stiffness is 50 kilopascals. Higher degrees of stiffness indicate liver fibrosis. More than 11 kilopascals indicates that the client has cirrhosis. The imaging study may not be as reliable for patients who have excessive ascites or obesity. Some patients being assessed for liver disease require biopsies to determine the exact pathology and the extent of disease progression. This procedure can be problematic because a large number of patients are at risk for bleeding. Even a percutaneous biopsy can pose a significant risk to the patient. To minimize this risk, an interventional radiologist can perform a liver biopsy using a long sheath through a jugular vein that then is threaded into the hepatic vein and liver. A tissue sample is obtained for microscopic evaluation. If a biopsy procedure is not possible, a radioisotope liver scan may be used to identify cirrhosis or other diffuse disease. The primary healthcare provider may request arteriography if US is not conclusive in finding portal vein thrombosis. To evaluate the portal vein and its branches, a portal venogram may be performed instead by passing a catheter into the liver and portal vein. This procedure is described in the transjugular intrahepatic portal systemic shunt section. The primary healthcare provider may perform an esophagogastroduodenoscopy to directly visualize the upper GI tract to detect complications of liver failure. These complications may include bleeding or oozing esophageal varices, stomach irritation and ulceration, or duodenal ulceration and bleeding. EGD is performed by introducing a flexible fiber optic endoscope into the mouth, esophagus, and stomach while the patient is under moderate sedation. A camera attached to the scope permits direct visualization of the mucosal lining of the upper GI tract. An endoscopic retrograde cholangiopancreatography uses the endoscope to inject contrast material via the sphincter of Oddi to view the biliary tract and allow for stone removals, sphincterotomies, biopsies, and stent placements if required. These procedures are described in more detail in Chapter 48. Analysis: analyze cues and prioritize hypotheses. The priority collaborative problems for patients with cirrhosis include 1. Fluid overload due to third spacing of abdominal and peripheral fluid. 2. Potential for hemorrhage due to portal hypertension and subsequent GI varices. 3. Acute confusion and other cognitive changes due to increased serum ammonia levels and/or alcohol withdrawal. 4. Pruritus due to increased serum bilirubin and jaundice. Planning and implementation: generate solutions and take action. Managing fluid volume. Planning: expected outcomes. The patient with cirrhosis is expected to have less excess fluid volume as evidenced by decreased ascites and peripheral edema, as well as adequate circulatory volume. Interventions. Fluid accumulations are minimal during the early stages of cirrhosis. Therefore, nursing and interprofessional interventions are aimed at preventing the accumulation of additional fluid and decreasing any existing fluid collection. Non-surgical treatment measures are used to treat ascites in most cases. Supportive measures to control abdominal ascites include nutrition therapy, drug therapy, paracentesis, and respiratory support. The patient's fluid and electrolyte balance is carefully monitored during the treatment period. Nutrition therapy. The primary healthcare provider usually places the patient with early abdominal ascites on a low-sodium diet as an initial means of controlling fluid accumulation. The amount of daily sodium intake restriction varies, but a 1 to 2 g Na plus restriction may be tried first. In collaboration with the registered dietitian nutritionist, explain the purpose of the restriction and advise the patient and family to read the sodium content labels on all food and beverages. Table salt should be completely excluded. Low-sodium diets may be distasteful, so suggest alternative flavoring additives such as lemon, vinegar, parsley, oregano, and pepper. Remind the patient that seasoned and salty food is an acquired taste. In time, he or she will become used to the decrease in dietary sodium. In general, patients with late-stage cirrhosis are malnourished and have multiple dietary deficiencies. For vitamin supplements such as thiamine, folate, and multivitamin preparations are typically given because the liver cannot store vitamins. For patients with biliary cirrhosis, bile may not be available for fat-soluble vitamin transport and absorption. Oral vitamins are prescribed when fluid administration is discontinued. Drug therapy. The primary healthcare provider usually prescribes a diuretic to reduce fluid accumulation and prevent cardiac and respiratory problems. Monitor the effect of diuretic therapy by weighing the patient daily, measuring daily intake and output, measuring abdominal girth, documenting peripheral edema, and assessing electrolyte levels. Serious fluid and electrolyte imbalances, such as dehydration, hypokalemia, and hyponatremia, may occur with loop diuretic therapy. Depending on the diuretic selected, the provider may prescribe an oral or 4-potassium supplement. Some clinicians prescribe furosemide and spironolactone as a combination diuretic therapy for the treatment of ascites. Because these drugs work differently, they are used for maintenance of sodium and potassium balance. For example, furosemide causes potassium loss, whereas spironolactone conserves it in the body. All patients with ascites have the potential to develop spontaneous bacterial peritonitis from bacteria in the collected acidic fluid. In some patients, mild symptoms such as low-grade fever and loss of appetite occur. In others, there may be abdominal pain, fever, and change in mental status. When performing an abdominal assessment, listen for bowel sounds and assess for abdominal wall rigidity. Treatment involves cefotaxime or other third-generation cephalosporins or fluoroquinolones. Paracentesis. For some patients, abdominal paracentesis may be needed if ascites affects respiratory effort. A paracentesis is an invasive procedure performed to remove abdominal fluid. The procedure is performed at the bedside, in an interventional radiology department, or in an ambulatory care setting. The primary healthcare provider inserts a trocar catheter or drain into the abdomen to remove the acidic fluid from the peritoneal cavity. This procedure is done using ultrasound for added safety. In some situations, a short-term ascites drain catheter may be placed while the patient is awaiting surgical intervention, or tunneled ascites drains can allow a patient or family caregiver to drain acidic fluid at home. Nursing implications associated with this procedure are described in the Best Practice for Patient Safety and Quality Care box, the patient having a paracentesis. Best Practice for Patient Safety and Quality Care, the patient having a paracentesis. 1. Explain the procedure and answer patient questions. 2. Obtain vital signs, including weight, before the procedure. 3. Ask the patient to void before the procedure to prevent injury to the bladder. 4. Position the patient in bed with the head of the bed elevated. 5. Monitor vital signs per protocol or primary healthcare provider request during the procedure. 6. Measure the drainage and record accurately. 7. Document the characteristics of the collected fluid. 8. Label and send the fluid for laboratory analysis. Document in the patient health record that specimens were sent. 9. After the catheter is removed, apply a dressing to the site. Assess for leakage. 10. Maintain bed rest per protocol. 11. Take vital signs and weigh the patient after the paracentesis. Document in the patient record weight both before and after paracentesis. If SBP is suspected, a sample of fluid is withdrawn and sent for cell count and culture. If the patient has symptoms of infection, the primary healthcare provider may prescribe antibiotics while awaiting the culture results. Respiratory support. Excessive acidic fluid volume may cause the patient to have respiratory problems. He or she may develop hepatopulmonary syndrome. Dyspnea develops as a result of increased intra-abdominal pressure, which limits thoracic expansion and diaphragmatic excursion. Auscultate lungs every 4 to 8 hours for crackles that could indicate pulmonary complications, depending on the patient's overall condition. Nursing safety priority. Action alert. For the patient with hepatopulmonary syndrome, monitor his or her oxygen saturation with pulse oximetry. If needed, apply oxygen therapy to ease breathing. Elevate the head of the bed to at least 30 degrees or as high as the patient wants to improve breathing. This position, with his or her feet elevated to decrease dependent ankle edema, often relieves dyspnea. Remind assistive personnel to weigh the patient daily every morning before breakfast using the same scale. Fluid and electrolyte balance problems are common as a result of the disease or treatment. Laboratory tests, such as blood urea nitrogen, serum protein, hematocrit, and electrolytes, help determine fluid and electrolyte status. An elevated BUN, decreased serum proteins, and increased hematocrit may indicate hypovolemia. If medical management fails to control ascites, the primary healthcare provider may choose to divert ascites into the venous system by creating a shunt. Patients with ascites are poor surgical risks. The transjugular intrahepatic portal systemic shunt is a non-surgical procedure that is used to control long-term ascites and reduce variceal bleeding. This procedure is described in the discussion of interventions in the Preventing or Managing Hemorrhage section that follows. Preventing or managing hemorrhage. Planning, expected outcomes. The patient is expected to be free of bleeding episodes. However, if he or she has a hemorrhage, it is expected to be controlled by prompt, evidence-based professional interventions. Esophageal variceal bleeds are the most common cause of upper GI bleeding. Interventions. All patients with cirrhosis should be screened for esophageal varices by endoscopy to detect them early before they bleed. If patients have varices, they are placed on preventive therapy. If acute bleeding occurs, early interventions are used to manage it. Because massive esophageal bleeding can cause rapid blood loss, emergency interventions are needed. The role of early drug therapy is to prevent bleeding and infection in patients who have varices. A non-selective beta-blocking agent such as propranolol is usually prescribed to prevent bleeding. By decreasing heart rate and the hepatic venous pressure gradient, the chance of bleeding may be reduced. Up to 20% of cirrhotic patients who are admitted to the hospital as a result of upper GI bleeding have bacterial infection, and even more patients develop healthcare-associated infection, usually cellulitis, urinary tract infections, or pneumonia. Infection is one of the most common indicators that patients will have an acute variceal bleed. Therefore, cirrhotic patients with GI bleeding should receive antibiotics when admitted to the hospital. If bleeding occurs, the healthcare team intervenes quickly to control it by combining vasoactive drugs with endoscopic therapies. Vasoactive drugs, such as octreotide acetate and vasopressin, reduce blood flow through vasoconstriction to decrease portal pressure. Octreotide also suppresses secretion of gastrin, serotonin, and intestinal peptides, which decreases GI blood flow to help with pressure reduction within the varices. Vasopressin is used less commonly because it is a very potent drug. Endoscopic therapies include ligation of the bleeding veins or sclerotherapy. Both procedures are very effective in controlling bleeding and improving patient survival rates. Esophageal varices may be managed with endoscopic variceal ligation. This procedure involves the application of small O bands around the base of the varices to decrease their blood supply. The patient is unaware of the bands, and they cause no discomfort. Endoscopic sclerotherapy, also called injection sclerotherapy, may be done to stop bleeding. The varices are injected with a sclerosing agent via a catheter. This procedure is associated with complications such as mucosal ulceration, which could result in further bleeding. If rebleeding occurs, rescue therapies are used. These procedures include a second endoscopic procedure, balloon tamponade and esophageal stents, and shunting procedures. Short-term esophagogastric balloon tamponade with esophageal stents is a very effective way to control bleeding. However, the procedure can cause potentially life-threatening complications such as aspiration, asphyxia, and esophageal perforation. Similar to a nasogastric tube, the tube is placed through the nose and into the stomach. An attached balloon is inflated to apply pressure to the bleeding variceal area. Before this tamponade, the patient is usually intubated and placed on a mechanical ventilator to protect the airway. This therapy is used if the patient is not able to have a second endoscopy or TIPS procedure. The transjugular intrahepatic portal systemic shunt is a non-surgical procedure performed in interventional radiology departments. This procedure is used for patients who have not responded to other modalities for hemorrhage or long-term ascites. If time permits, patients have a Doppler ultrasound to assess jugular vein anatomy and patency. The patient receives heavy force sedation or general anesthesia for this procedure. The radiologist places a large sheath through the jugular vein. A needle is guided through the sheath and pushed through the liver into the portal vein. A balloon enlarges this tract, and a stent keeps it open. Most patients also have a Doppler ultrasound study of the liver after the TIPS procedure to record the blood flow through the shunt. Treating patients with TIPS who have esophageal/gastric varix hemorrhage problems may also require esophageal/gastric vein embolization as a part of the procedure. Patients with a highly cirrhotic liver usually have little flow through the liver parenchyma. These patients develop large portal esophageal veins diverting blood away from the diseased liver. Even after a successful TIPS, the diverting veins may persist and must be embolized so they will not rebleed. Serious complications of TIPS are not common. Patients are usually discharged in 1 or 2 days and are followed up with ultrasounds for the first year after the shunt is placed to ensure continued patency. Patients must also be monitored for hepatic encephalopathy, which can be caused by a TIPS. After creation of the TIPS, blood now bypasses most of the liver's filtration processes, allowing toxins to circulate throughout the body. For some patients, this can cause disturbances in consciousness and behavior. Lactulose or other medications may be given to counteract this effect, and dietary modification may also be helpful. In some cases, a TIPS may have to have the flow reduced or closed completely to reverse the encephalopathy. This is done by deploying a smaller stent or occluding device inside the original TIPS. This is a delicate decision for the healthcare provider to make because reduction of flow through the shunt will likely cause the initial esophageal hemorrhaging to recur. Patients receiving TIPS can also have significant elevation of their pulmonary artery pressure. This is a result of the sudden increase of blood flow to the right heart. Diuretics may help to treat this problem. For this reason, patients must be carefully evaluated for right heart failure before TIPS placement. Depending on the procedure done to control esophageal bleeding, patients usually have a nasogastric tube inserted to detect any new bleeding episodes. They often receive packed red blood cells, fresh frozen plasma, dextrin, albumin, and platelets through large-bore 4 catheters. Monitor vital signs every hour and check coagulation studies, including prothrombin time, partial thromboplastin time, platelet count, and international normalized ratio. Preventing or managing confusion. Planning, expected outcomes. The patient is expected to be free of acute or chronic confusion. However, if it occurs, it is expected that the interprofessional healthcare team will intervene early to maintain patient safety and prevent further health problems or death from encephalopathy. Interventions. Collaborative interventions are planned around the management of slowing or stopping the accumulation of ammonia in the body to improve mental status and orientation. Assess the patient's neurologic status and monitor during treatment. Because ammonia is formed in the GI tract by the action of bacteria on protein, non-surgical treatment measures to decrease ammonia production include dietary limitations and drug therapy to reduce bacterial breakdown. Patients with cirrhosis have increased nutritional requirements, high carbohydrate, moderate fat, and high protein foods. However, the diet may be changed for those who have elevated serum ammonia levels with signs of encephalopathy. Patients should have a moderate amount of protein and fat foods and simple carbohydrates. Strict protein restrictions are not required because patients need protein for healing. In collaboration with the registered dietitian nutritionist, be sure to include family members or significant others in nutrition counseling. The patient is often weak and unable to remember complicated guidelines. Brief, simple directions regarding dietary do's and don'ts are recommended. Keep in mind any financial, cultural, or personal implications and the patient's food allergies when discussing food choices to provide optimal patient-centered care. Drugs are used sparingly because they are difficult for the failing liver to metabolize. In particular, opioid analgesics, sedatives, and barbiturates should be restricted, especially for the patient with a history of encephalopathy. However, several types of drugs may eliminate or reduce ammonia levels in the body. These include lactulose or lactitol and non-absorbable antibiotics. The primary healthcare provider may prescribe lactulose to promote the excretion of ammonia in the stool. This drug is a viscous, sticky, sweet-tasting liquid that is given either orally or by NG tube. The purpose is to obtain a laxative effect. Cleansing the bowels may rid the intestinal tract of the toxins that contribute to encephalopathy. It works by increasing osmotic pressure to draw fluid into the colon and prevents absorption of ammonia in the colon. The drug may be prescribed to the patient who has manifested signs of encephalopathy, regardless of the stage. The desired effect of the drug is production of 2 or 3 soft stools per day and a decrease in patient confusion caused by this complication. Observe for response to lactulose. The patient may report intestinal bloating and cramping. Serum ammonia levels may be monitored but do not always correlate with symptoms. Hypokalemia and dehydration may result from excessive stools. Remind assistive personnel to help the patient with skin care if needed to prevent breakdown caused by excessive stools. Several non-absorbable antibiotics may be given if lactulose does not help the patient meet the desired outcome or if he or she cannot tolerate the drug. These drugs should not be given together. Older adults can become weak and dehydrated from having multiple stools. Neomycin sulfate or rifaximin, both broad-spectrum antibiotics, may be given to act as intestinal antiseptics. These drugs destroy the normal flora in the bowel, diminishing protein breakdown and decreasing the rate of ammonia production. Maintenance doses of neomycin are given orally but may also be administered as a retention enema. Long-term use has the potential for kidney toxicity and therefore is not commonly used for an extended period of time. It cannot be used for patients with existing kidney disease. Frequently assess for changes in level of consciousness and orientation. Check for Asterixosand fader hepaticus. These signs suggest worsening encephalopathy. Thiamine supplements and benzodiazepines may be needed if the patient is at risk for alcohol withdrawal. NCLEX Examination Challenge 532. Physiological integrity. The nurse is caring for a client in end-stage liver failure. Which interventions should be implemented when observing for hepatic encephalopathy? Select all that apply. A. Assess the client's neurologic status as prescribed. B. Monitor the client's hemoglobin and hematocrit levels. C. Monitor the client's serum ammonia level. D. Monitor the client's electrolyte values daily. E. Prepare to insert an esophageal balloon tamponade tube. F. Make sure the client's fingernails are short. Managing pruritus. Planning, expected outcomes. The patient is expected to experience less discomfort from pruritus as a result of comfort measures and possibly drug therapy. Interventions. Patients frequently report pruritus and dry skin as a result of jaundice from increased levels of serum bilirubin as cirrhosis progresses. Pruritus tends to increase in warmer conditions and in the early evening and at night. Therefore, comfort measures include avoiding being too warm, moisturizing the skin, and avoiding irritants to the skin. Some patients find that cool compresses and or corticosteroids creams provide temporary relief. If these measures are not effective, drug therapy, including selective serotonin reuptake inhibitors like sertraline, may be helpful. Care coordination and transition management. If the patient with late-stage cirrhosis survives life-threatening complications, he or she is usually discharged to home or to a long-term care facility after treatment measures have managed the acute medical problems. A home care referral may be needed if the patient is discharged to home. These chronically ill patients are often readmitted multiple times, and community-based care is aimed at optimizing comfort, promoting independence, supporting caregivers, and preventing rehospitalization. Interprofessional collaboration. Care of patients with cirrhosis. For patients with moderate to late-stage liver disease, collaborate with the case manager or other discharge planner to coordinate interprofessional continuing care. According to the Interprofessional Education Collaborative Expert Panel's competency of roles and responsibilities, using the unique and complementary abilities of other team members optimizes health and patient care. Collaborate with healthcare team members to help the client be as ADL independent as possible, including physical and occupational therapists. Patients with end-stage disease may benefit from hospice care. Home care management. In collaboration with the patient, family, and case manager, assess physical adaptations needed to prepare the patient's home for recovery. His or her rest area needs to be close to a bathroom because diuretic and or lactulose therapy increases the frequency of urination and stools. If the patient has difficulty reaching the toilet, additional equipment is necessary. Special adult-size incontinence pads or briefs may be helpful if the patient has an altered mental status and incontinence. If the patient has shortness of breath from massive ascites, elevating the head of the bed and maintaining him or her in a semi-Fowler to high Fowler position may help alleviate respiratory distress. Alternatively, a reclining chair with an elevated footrest may be used. Self-management education. The patient is discharged to the home setting with an individualized teaching plan that includes nutrition therapy, drug therapy, and alcohol abstinence. The patient who has a tunneled ascites drain will need to be taught how to access the drain and remove excess fluid. Review the home care instructions that are provided with the drainage system with both the patient and family/caregiver. Remind them not to remove more than 2,000 milliliters from the abdomen at one time to prevent hypovolemic shock. The patient with encephalopathy often finds that small, frequent meals are best tolerated. If his or her nutritional intake or albumin/prealbumin is decreased after discharge, multivitamin and oral nutritional supplements are usually needed. Teach patients to avoid excessive vitamins and minerals that can be toxic to the liver, such as fat-soluble vitamins, excessive iron supplements, and niacin. Remind patients to check with their primary healthcare provider before taking any vitamin supplement. The patient is often discharged while receiving diuretics. Provide instructions regarding the primary healthcare provider's prescription for the diuretic. Teach about side effects of therapy, such as hypokalemia. The patient may need to take a potassium supplement if he or she is taking a diuretic that is not potassium-sparing. If the patient has had problems with bleeding from gastric ulcers, the primary healthcare provider may prescribe an 2-receptor antagonist agent or proton pump inhibitor to reduce acid reflux. Patients who have had episodes of spontaneous bacterial peritonitis may be on a daily low-dose maintenance antibiotic. Teach family members how to recognize signs of encephalopathy and to contact the primary healthcare provider if these signs develop. Reinforce that constipation, bleeding, and infection can increase the risk for encephalopathy. Advise the patient to avoid all over-the-counter drugs, especially NSAIDs and hepatic toxic herbs, vitamins, and minerals. Reinforce the need to keep appointments for follow-up medical care. Remind the patient and family to notify the primary healthcare provider immediately if any GI bleeding is noted so that reevaluation can begin quickly. Home care management. In collaboration with the patient, family, and case manager, assess physical adaptations needed to prepare the patient's home for recovery. His or her rest area needs to be close to a bathroom because diuretic and or lactulose therapy increases the frequency of urination and stools. If the patient has difficulty reaching the toilet, additional equipment is necessary. Special adult-size incontinence pads or briefs may be helpful if the patient has an altered mental status and incontinence. If the patient has shortness of breath from massive ascites, elevating the head of the bed and maintaining him or her in a semi-Fowler to high Fowler position may help alleviate respiratory distress. Alternatively, a reclining chair with an elevated footrest may be used. Self-management education. The patient is discharged to the home setting with an individualized teaching plan that includes nutrition therapy, drug therapy, and alcohol abstinence. The patient who has a tunneled ascites drain will need to be taught how to access the drain and remove excess fluid. Review the home care instructions that are provided with the drainage system with both the patient and family/caregiver. Remind them not to remove more than 2,000 milliliters from the abdomen at one time to prevent hypovolemic shock. The patient with encephalopathy often finds that small, frequent meals are best tolerated. If his or her nutritional intake or albumin/prealbumin is decreased after discharge, multivitamin and oral nutritional supplements are usually needed. Teach patients to avoid excessive vitamins and minerals that can be toxic to the liver, such as fat-soluble vitamins, excessive iron supplements, and niacin. Remind patients to check with their primary healthcare provider before taking any vitamin supplement. The patient is often discharged while receiving diuretics. Provide instructions regarding the primary healthcare provider's prescription for the diuretic. Teach about side effects of therapy, such as hypokalemia. The patient may need to take a potassium supplement if he or she is taking a diuretic that is not potassium-sparing. If the patient has had problems with bleeding from gastric ulcers, the primary healthcare provider may prescribe an 2-receptor antagonist agent or proton pump inhibitor to reduce acid reflux. Patients who have had episodes of spontaneous bacterial peritonitis may be on a daily low-dose maintenance antibiotic. Teach family members how to recognize signs of encephalopathy and to contact the primary healthcare provider if these signs develop. Reinforce that constipation, bleeding, and infection can increase the risk for encephalopathy. Advise the patient to avoid all over-the-counter drugs, especially NSAIDs and hepatic toxic herbs, vitamins, and minerals. Reinforce the need to keep appointments for follow-up medical care. Remind the patient and family to notify the primary healthcare provider immediately if any GI bleeding is noted so that reevaluation can begin quickly. Nursing safety priority. Action alert. One of the most important aspects of ongoing care for the patient with cirrhosis is health teaching about the need for the client to avoid acetaminophen, alcohol, smoking, and illicit drugs. By avoiding these substances, the patient may 1. Prevent further fibrosis of the liver from scarring. 2. Allow the liver to heal and regenerate. 3. Prevent gastric and esophageal irritation. 4. Reduce the incidence of bleeding. 5. Prevent other life-threatening complications. Healthcare resources. The patient with chronic cirrhosis may require a home care nurse for several visits after hospital discharge. The home care nurse can monitor the effectiveness of treatment in controlling ascites. The encephalopathic patient may need to be monitored for adherence to drug therapy and alcohol abstinence, if appropriate. Individual and group therapy sessions may be arranged to help patients deal with alcohol abstinence if they are too ill to attend a formal treatment program. Because some patients may have alienated relatives over the years because of substance use, it may be necessary to help them identify a friend, neighbor, or adult in their recovery group for support. If needed, refer the patient and family to self-help groups, such as Alcoholics Anonymous and Al-Anon. In Canada, Smart Recovery offers similar support, as well as additional services to control addictions. The patient with cirrhosis may also desire spiritual or other psychosocial support. Finances are frequently a problem for the chronically ill patient and family. Social support and community services need to be identified. The American Liver Foundation and American Gastroenterological Association are excellent sources for more information about liver disease. For patients who are not candidates for liver transplantation, address end-of-life issues. Discuss options such as hospice care with patients and their families. Be aware that they will go through a grieving process and will perhaps be in denial or very angry. Evaluation. Evaluate outcomes. Evaluate the care of the patient with cirrhosis based on the identified priority patient problems. The expected outcomes include that the patient will 1. Have a decrease in or have no ascites. 2. Achieve fluid and electrolyte balance. 3. Not have hemorrhage or will be managed immediately if bleeding occurs. 4. Not develop encephalopathy or will be managed immediately if it occurs. 5. Successfully abstain from alcohol or drugs and have adequate nutrition.